Welcome, everyone, to the latest installment of EMS Focus, a collaborative federal webinar series. I'm John Kramer, and I'm the director of the NHTSA Office of EMS. Together with our federal partners, NHTSA's Office of EMS is focused on advancing a national vision for EMS. The projects we undertake and the resulting resources for the community help with systems improvements, measuring the health of EMS systems nationwide, and delivering the data that EMS leaders need to advance their individual systems. Another role of the office is to educate the EMS community on new innovations, processes, and technologies that can, in the end, help provide better and more efficient patient care. This free webinar series hosted by the NHTSA Office of EMS is a unique opportunity for federal EMS agencies and industry experts to share information with the EMS community. EMS Focus conducts webinars several times throughout the year on issues that are important to the EMS community, and we hope provides you with timely information on what federal agencies are doing about them. Today's webinar is being recorded and will be archived on ems.gov for future viewing and listening. More information on the EMS Focus webinar series can be found at ems.gov. Every year, more than 250,000 people experience an out-of-hospital cardiac arrest in the United States, but fewer than half of them receive CPR before professional help arrives, even though it's well known that early CPR can greatly increase an individual's chance of survival. And when EMS resources do get on scene, not every patient gets the same highly coordinated approach to CPR that's been shown to make the most difference. In 2015, the National Academies published a document entitled Strategies to Improve Cardiac Arrest Survival, A Time to Act. In this landmark report, the authors identified opportunities to increase survival and made specific recommendations to several entities, including the National Highway Traffic Safety Administration. In response to the report's recommendations, our NHTSA Office of EMS brought leaders from the EMS and 911 communities together to develop resources that would help local communities implement telecommunicator and high-performance CPR programs in their EMS systems. Today, our speakers are going to share more about this initiative, as well as one local effort that has shown the real difference that early and effective CPR can make in a community. In this webinar, our guests will demonstrate how creativity, advocacy, and a focus on the greater good paved the way for a true collaboration between 911 and field EMS personnel, a collaboration that has already saved numerous lives in Central Oregon. And we'll also learn about CPR Life Links, a national effort to create a training and implementation toolkit based on lessons learned from Oregon and various other communities to help people across the country do the same thing. Having 911 telecommunicators and EMS field personnel work together to change the culture of their organizations and make saving the lives of cardiac arrest victims an expectation, not a surprise. We have a great panel of speakers with us today. Megan Craig is the training coordinator for Deschutes County 911 program in Bend, Oregon. Megan began her career there as an emergency telecommunicator more than 20 years ago. Peter Hosek is the EMS training officer for the Bend Fire Department, also in Bend, Oregon. He's been with the fire department for the past 18 years. Working together, they developed a collaborative and very innovative and effective program that they'll be sharing with you. Dr. Bentley Bobrow is the project lead for the CPR Life Links project. He's a professor of emergency medicine at the University of Arizona College of Medicine. He serves as the medical director for the Arizona Bureau of Emergency Medical Services and Trauma Systems, and started the Save Hearts in Arizona Registry and Education Program, a unique statewide out-of-hospital cardiac arrest system that aims to improve outcomes for time-sensitive emergency medical conditions. The panel will share details about the LifeLinks CPR program and progress that's been made in improving CPR programs throughout the country. But first, we'd like to start with the why we do this and hear from the folks who spearheaded the effort in Oregon. Megan and Peter, I'll turn it over to you.
All right. Good morning. This is Peter Hossick from Bend Fire and Rescue.
And Megan Craig from Deschutes County 911.
And a pleasure to have all of you with us this morning. First, Megan and I would definitely like to thank NHTSA and Red Flash Group for hosting us today, and the many people who devoted their time to help developing the LifeLinks paper today. Also, a special shout out to Seattle and the Resuscitation Academy, who helped train us initially in resuscitation and helped point out where we needed to do better. Next slide. So this first slide was a quote kind of at the beginning of my Resuscitation Academy class. Back in 2012, I had the pleasure of going up there and getting trained by Seattle, and this is kind of one of the first slides that they had from one of their past alumni. And at this time, you know, even in my own fire department, when I told them, hey, I'm going to go do a couple days of study up with Seattle on, you know, CPR and cardiac arrest, and they're going, you're going to CPR camp for 2 days? We can't get that done in a couple hours? But it was super informative, and I learned very much, more than I had learned in paramedic school, about how important each of the links in the chain of survival were. So Chief McCallan here has a great quote. We would tear our department apart and rebuild it step by step if we thought we were losing 4 to 6 citizens per year that should have been rescued from fires. So when we know we can save 4 to 6 additional people every year from cardiac arrest, are we as an agency going to step up and put the same energy into saving these CPR patients? To the family, dead is dead and equally tragic, so why would we spend any less effort saving these patients? Absolutely. The chief hit the nail on the head there. And when we came back to Bend, we're like, we need to look at where we're at. Next slide. So when we started out here, I'd have to say that Bend Fire was hardly the pinnacle of representation of this. We really had a very siloed system. And talking to some of the people in my class up there during the academy, I think we were not uncommon. We all kind of had our parts to play, but maybe we didn't communicate a ton with each other. And like with 911, I think the last time I had been into the center was maybe 15 years prior as an EMT. I hadn't set foot in there. They were just the people who talked to me on the radio. So one of the first things we kind of came back was, I came back to the EMS chief and said, hey, chief, I learned all this great stuff up at the academy. Hey, they're talking about resuscitation percentages. What's ours? How are we doing in Bend? It's like, oh, we're good at this. I go, yeah, they actually had a number. Do we have a number? And he's like, yeah, we're good at this, but no, we don't have a number. So one of our first things was, okay, well, we need to get to a baseline. What is our survival number? And when we ran back through our records, we found that we were running 20% survival from witness cardiac arrest here in Bend, which was far below the national average at that time, which was probably running about 33. So our physician advisor and medical director was with us, and we just said, hey, we have to do better. So one of the things was we got to reach out to some of our stakeholders. Who else can help us out in this program? Next slide. So I quickly realized with all that great information I'd learned, I could really only affect one piece of the chain of survival, which was really in-house training. So I can train all of our guys up, and we did that immediately. We're going to do high-performance CPR. We're going to be better about pauses, all those things that I can train my guys in-house. But as we learned in Seattle, hey, the first 3 links we don't actually control. You know, getting early telephone CPR, early hands-on chest, early defibrillation, all those lie outside of my agency. So really, dispatch controls our destiny on some of these cardiac arrests. So we knew we had to get their help. Next slide. And this slide does a really good job of representing how important each circle is. And if you look at the small circles, which unfortunately, if you count on fire EMS alone to do this for you, they're about 10% as big as those first one and then the second one also. They're much smaller. So dispatch controls a ton of our destiny on these things. It is so important that we have their help. And so with that, I'm like, kind of being politically naive, I'm like, shoot, I'll just tromps right down over to 911 and see if these guys will help me with this. And luckily they were nice enough to humor me and got in the center and kind of met Megan Craig for the first time back in 2013 and said, hey, Megan, learned all this great stuff. Can you help me out? I think we need to work together and see where we're at. I'm looking at our averages here. We're running about 20%. And I think let's look at if we can do better.
Next slide, please. So when Peter first showed up with what he had learned, it made me consider what our culture was around cardiac arrest calls. At the time, we were only reviewing those calls if they were part of our random sampling. There was not a focus on to get quickly to CPR. The first thing we did was started listening to all cardiac arrest calls that occurred in Bend together. I recognize this is not realistic for larger centers, but even a small sampling would be insightful. By doing this, we were able to establish a baseline and identify and prioritize areas to work on. So through listening to the calls and talking to the dispatchers, we realized that our first focus was on changing the culture from the thought of they are beyond help when they call to believing that people in cardiac arrest are savable and that dispatch has a key role. We did this by having Peter start teaching a 1-hour class on the science behind CPR with a focus on how impactful early intervention was and that we as a 911 center were that early intervention. Those 2 slides he had just shared were part of that presentation and really hit home for us. We also changed the way we certified and recertified in CPR. This might seem like a small piece, but it was very impactful to get an instructor in here that had a passion for high performance CPR. And she would include the reasons why we were doing what we were doing in that CPR class. And it was very hands-on. We were on the ground with the dummies that had feedback for you. And the dispatchers realized how exhausting it was and how important it was to get the caller to put us on speaker quickly so that they could put their focus on the person that needed them. It also showed them the importance of switching out. So if you're doing CPR for a long period of time, you're going to get tired. So we were able to practice how do we switch out those first people on scene so that CPR stays good. And then the reason why we want to remind them that it's important to give those instructions again throughout your time on the phone. So going 2 inches deep, making sure the chest will come all the way back up. And having a CPR class that really put all that into play was huge for us. And then we have lots of conversations on the dispatch floor around this topic. We wanted to understand what the different roadblocks were that the dispatchers had and try to remove them. And Peter was instrumental in this because he was able to reassure them that it was better to do CPR on an unconscious person that did not need it than to fail to get CPR started. And then we also learned in talking to dispatchers that they really wanted to know the outcome, even if the person had passed away. And they also wanted feedback on how they could do that same type of call better the next time. We worked and continue to work to get that information and feedback to them on a regular basis.
Yeah, and I think what Megan mentioned about the culture is super important here. When we started also in the fire department, that the belief that a lot of these people didn't survive really prevailed inside the fire department also. We just didn't think, and we were literally a self-fulfilling prophecy. We didn't believe they survived. Maybe we're not quick enough on, transitions and stuff. So we were reinforcing our own beliefs. So we really, culturally, we had to challenge that belief initially. And that was a little bit of a heavy lift. I think one of the other important things about Telefon CPR is that just because someone dies and we gave them really good instructions, that is not a failure of Telefon CPR. We just might not have had, that person may have been unsavable from the get-go, unwitnessed downtimes and that stuff like that. So it's really important that we train to be really fast on every single person, because the next person who calls in cardiac arrest, well, they wouldn't call in cardiac arrest, but the person who would call for cardiac arrest, that person may very much be savable. And being fast and getting those instructions out there, coaching those people as we go through, super important.
And so this leads us to our next slide. With all the change and the feedback, it was really important that we also recognize the improvements along the way, even small improvements. So in addition to that feedback and trying to close those those gaps and what happened with patients, we started really celebrating as a center. We gave out life-saving pins. The fire department, including Peter, would come in and celebrate with us. So it helped us to realize that we were part of something bigger. And then that leads us to the biggest reason this all works out. Next slide, please.
Yeah, and so the fire department moved on to, we started hosting all of our survivors and most specifically any citizen CPR performers there. And so we had the crews come, plus the dispatchers, plus, as you can see, police. A lot of times in 14, we were able to have the Bend Police Department help us a ton with this. I can't say enough good about those guys too. And really build a true EMS system of survival where it's all of us on deck to try and save people because we know every minute counts. So having these award ceremonies, letting the families meet all the people who are involved in their arrest, they've been a huge success. It's great. And here is your cultural change in reality. So it only took meeting just one or two people who they were down on the floor dead, and then they're meeting the crews. They're like, oh, maybe this does work. And that started changing the culture around the fire department and I think in dispatch a little bit.
Absolutely. This was an essential piece for us. And ironically, when we first had our first survivor come in and talk to us, it was almost uncomfortable for us because we're so used to being behind the scenes. But he was so generous with his experience. And now we all get excited for each other around this. So the culture today, if you were to just ask people here, we're going to do CPR. It's not a question of it at all. We're going to do it and do our best to encourage the people in our community to get that started. And the other thing we noticed is an increase in CPR classes and people attending CPR classes as this started spreading throughout our community.
Yeah, absolutely. A lot of these people will get 20, 30, 40 of their friends to come in and do CPR right after they've had a survivor, and then they'll come and talk to their friends about it. So each time we save somebody, we get a big uptick in, community related classes for CPR. So the effect kind of spreads out from there. And a lot of times now we'll have one of these survivors come to and talk to every one of our rookie classes, kind of instill that culture right from the start about how important this is. And here it is standing in front of you. This really does work. But all pieces must work together. Again, the siloed system we started with wouldn't necessarily make this successful. Even being as good as someone like Seattle, you've got to have all the pieces working together or you're not going to have those high save rates.
Yep. Thank you again for having us and taking the time out to listen to this webinar.
Yeah, we'll turn it back over to the docs to kind of talk about the details here.
Megan and Peter, thank you so much for sharing that information. And you really are to be complimented on breaking down the silos, bringing the communities together, and really going beyond just bringing the communities together, but having a significant impact on your community overall. I want to remind listeners, please feel free to submit questions. We will be pulling them together and addressing them toward the end of the discussion. We will definitely have time for questions and answers at the end. And just a reminder that the program is being recorded, so if you want to share this information with other folks in your systems, later on they'll be archived on ems.gov. It's now my privilege to introduce Dr. Bobrow. Ben, I'll turn it over to you.
Okay, thanks, Dr. Kramer. First of all, like you, I really want to thank and congratulate Megan and Peter on their outstanding life-saving work in Bend, Oregon. They're showing, and other communities are also starting to show us that we can dramatically improve cardiac arrest survival across the country. It's not only the few elite departments that Peter mentioned, the King County, Seattle departments, really led by the giants like Drs. Eisenberg and Ray and Sayer, but it's the rest of us. We can do this. We can implement and measure these proven strategies and save many more lives. I also really, at the very start of this, I want to tell you how grateful we are for our federal partners in this, NHTSA, Dr. Kramer your office, Lori Flaherty, Dave Bryson, your entire team, and really for their tremendous leadership in this effort, and I must say in other EMS efforts, implementation efforts that you've led over the years. So let's start off. Next slide. As Dr. Kramer highlighted, cardiac arrest, out-of-hospital cardiac arrest, is a leading killer in our country, claiming nearly 1,000 lives every single day. 1,000 lives today will be lost. And as a country, sadly, our survival rates overall are still poor. Next slide. This fact was the impetus for the IOM report released in 2015. The report took a 360-degree look at the major public health problem of cardiac arrest and cardiac arrest care, and what is really needed to improve survival on a national scale. Next. Some of the highlights of this 440-page report, which I urge you to take a look at. I don't expect you to read the whole thing, but I would love if you did, is that CPR is really the key intervention, but not just any CPR. Because cardiac arrest is such a time-sensitive condition, literally minutes make the difference between life and death. And what we know now is that early CPR and high-performance CPR are really the keys. And we don't, for many different reasons, always do a great job engaging, for example, engaging lay rescuers at the scene, or even with the quality of our professional rescuer CPR. Next. As a result of this, we have huge and really unacceptable variations in cardiac arrest survival, on the order of 5-fold differences in survival between similar communities. We also, as an aside, have huge socioeconomic disparities in who lives and who dies from cardiac arrest. Next. Some communities, however, have proven over time that they can save many, many more lives across all these different groups, regardless of socioeconomics, by meticulously implementing and measuring their CPR process. Next. In essence, the report underscores that 911 and EMS working together as a cohesive system, as you heard very clearly from our colleagues in Bend, Oregon, is what works best in real life. Next. The IOM report had 8 summary recommendations, and number 3 of these you see here: enhance the capabilities and performance of EMS systems. This was the genesis of what we have all come together to accomplish. This CPR Life Links project, which aims to fulfill this recommendation. Next. A central concept is that the key interventions like telecommunicator CPR, we know it is not enough to say, we do that, or yeah, we're good at that, which you heard from Peter. But training and measurement, details about how long, for example, it takes to recognize cardiac arrest over the phone, and how long it takes to get those first life-saving precious compressions started, and meeting or exceeding what we believe now are the performance standards for these key interventions. Next. Same idea for trained EMS rescuer CPR. It comes down not so much at all to medications or advanced procedures, but rather to the quality of that CPR being delivered at the scene. The details of the interruptions, the pauses, how many, how long, the depth of the compressions, were the compressions released between each one, the rate, the amount of ventilation, These details are what makes the difference between a funeral and a survivor's reunion. These things may be simple, but they're not at all easy to implement. Next. So these are our project deliverables given to CPR Life Links from NHTSA. This is the really hard work of translating things from science to guidelines to implementation on the streets. And you see each of these project deliverables are addressed in the CPR Life Links project. Finally, you see one of our project deliverables was to create widespread awareness and adoption around these tools, which have been highly operationalized for your use. This is really what we're engaging each of you with this next phase of the project, to widely implement, measure, and disseminate these tools. Next. This is an overview of some of the content that you will be receiving in CPR Life Links. We talked a lot about the name of this effort, and our media experts at Red Flash really helped us settle on the term CPR Life Links, because it really highlights that the foundation of this is the key partnership between 911 and EMS, which is so often underappreciated and underdeveloped. That relationship and collaboration can save many, many lives, both from cardiac arrest and from other key time-sensitive conditions. The content in CPR Life Links is intended as a complete implementation toolkit, which is much different than often what you see in standard guidelines. What we really tried to do is to provide a how-to solution that you can take and implement. Next. One of the key differences between guidelines, for example, and CPR Life Links is that we discuss in detail and give you real-life circumstances, challenges, and perspectives from around the country on these key issues. Things like staffing, lack of medical direction, perceived liability concerns by 911 centers. All of these things that you see are real-life challenges, whether you want to call them challenges or barriers. They're tough, and it's hard to figure it out sometimes. And one of the things that we focused on was discussing these challenges, which are actually quite common across the country. And we give links and examples of real-life ways that agencies overcame these challenges. Next. Similarly, with the high-performance CPR modules, we talk about different challenges, which are often related but distinct from the telecommunicator CPR challenges. These are very operational concerns because, again, this product is intended to help organizations overcome these real-world challenges. Next. This is an example of the format of some of the training for both the telecommunicator and high-performance CPR modules. Not only the cognitive of learning, but just as much, if not more, the psychomotor skill acquisition and the proficiency and maintenance of competency issues for providers. This is all addressed and packaged for you to use with your agencies. Next. This is a short list, not a comprehensive list, of some of the partners that have been involved with this so far. This list continues to grow. We've been very blessed working with not just the NHTSA team, but the leaders from across the country who have walked these same paths in your shoes. And they really are passionate about sharing their wisdom, and their experience to help improve care and save lives. Next. What can you do? Your input is absolutely vital in this project. The content is now posted for public comment. You see the links there on both ems.gov and 911.gov websites. We urge you to take a look and provide your constructive feedback. This is not at all a static document. It's still evolving, and your experience and your insight is not just welcome, it's needed. Next. These materials, when published, will be made available on the ems.gov and 911.gov websites in a toolkit format. There will be different versions of training materials, audiovisual materials, presentations. We really tried to focus on how to put this together from your perspective. What would be the most useful, the most helpful? And so our intent is that these materials can all be downloaded for free, and you can deliver this content. You will become the experts in this and deliver it, and then that's our plan for widely disseminating this information. Next. Again, this is where you can find the materials when they're finally published, both ems.gov and 911.gov. Next. So what can you do? Hopefully we piqued your interest. That was our hope. But you can already start right now, even before the materials are published and made formally available. Again, we urge you to provide public comment before October 1st, but you can even start today by building that relationship, as you heard from Peter and Megan, building that relationship between your 911 center and your EMS agency. Start with the CPR dialogue. It's a great icebreaker. It's a great place to start. You can promote and disseminate the CPR Life Links materials when they come out, both locally, regionally, and we hope nationally. There will be opportunities for people to deliver messages and presentations on this at national meetings. You know, we will only be able to disseminate this so far as a small group, but using force multipliers across the country, that's our plan to widely disseminate this everywhere. And finally, you can start by asking the key question, which Peter asked when he came back from the Resuscitation Academy. And he asked his chief at Bend, Oregon, what's our survival rate? It's a simple question. Start by measuring. Once you know that, then you start to get an idea of what you need to do. Again, the implementation and measurement is the focus of this, and that's a common theme throughout all of this. So you can start by implementing and measuring and saving lives. It won't take long. Next. Finally, I want to thank you again, thank all of our federal partners, thank everyone, Megan, Peter, and especially our experts at Red Flash who have been putting this all together and really guiding this. Thank you again to everyone who tuned in. You have an important life-saving role in all of this, and we appreciate what you do. We appreciate your dedication to saving lives. So, Dr. Kramer, I'm going to turn it back over to you. Thank you.
Thanks so much, Dr. Bobrow, and thank you for the great job you have done leading the CPR LifeLinks project and corralling all of the folks who have been involved in the project. You obviously have a great group of folks to work with, but you've done a nice job of bringing them all together. One of the, or several times during the conversation so far, folks have mentioned the Resuscitation Academy, a program that was started in Seattle, King County. I would encourage folks who are interested in that program to Google it, gather more information about that. There are a number of states that, working with the Seattle-King County Resuscitation Academy, have established state programs emulating the same thing as well. So please feel free to look into that. I want to remind folks that, or encourage folks to continue to submit questions. We've had questions come in throughout the entire webinar so far. We will be getting to as many of those questions as we can, but if we happen to run out of time, we will be cataloging the questions and asking the panelists to address the questions that have been submitted but not covered during the live webinar, and we'll make sure that those are distributed as well. Want to turn first back to Megan and Peter. You were talking about the feedback that you provided. Can you sort of elaborate on that a little bit and talk about what the feedback involves, how quickly you're able to provide it, and just how have you incorporated that feedback component into the process?
Yeah, this is one of our bigger challenges. I think most people can relate to this. When we work shift work like that, how do we get timely feedback to people, considering we also have lots of other responsibilities in our jobs? So if we were listening to calls that day and that call taker dispatcher was working, we would actually, as soon as we were done listening to calls, go out and talk to them on the dispatch floor. So it was very immediate feedback in a group setting, always positive, and here's how we could do better next time, or great job on this was what we did a lot, just so other people in the room could hear about that. And on each of those, it always ended up being a conversation with all the dispatchers in that area. So it was awesome. We also then would, if they weren't working, we'd send emails, or I would set myself a tickler to go back when that person was working and talk with them. If it was a call that maybe there was something that really could go better, then we would just, next time we were working together, that person would come in, we would listen to the call together. And most of the time, the dispatcher knows what they could have done better. And it's just then on the next call, here's something to consider. So we also have a formal queue program. So there's actually a form that you get. We use National Queue, which is a company that does queue. So there's lots of ways to do the feedback.
Yeah, I think the other important thing is certainly when we started and stuff, and we heard some of our first calls that maybe weren't where we wanted to be yet. We made sure to, like Megan pointed out, be really positive about this, and then kind of point out areas for change, but not use the data that we were getting to basically beat people over the heads with it. Much more like, hey, here's some things to think about, try to be a little faster here. Okay, they said some key words here to indicate they might have been in cardiac arrest. Can you hear that in the background? That's agonal respiration. So really making it a teachable moment, certainly not a punishing moment.
Absolutely.
You mentioned when you were describing particularly the engagement with survivors and survivors' families, that you noticed an uptick in community CPR courses. How did the community become aware of this program and even know that it existed, such that they figured, well, I better take a CPR course? Was there a community education component to your program?
Yeah, so actually whenever we do those survivor kind of celebrations, we'd invite the press. Most of all, we go to the patients and say, hey, this is entirely up to you. We're happy just to have your family and friends in to do this, but we would like to, your loved one, your wife, your husband, your son or daughter did CPR on you, and we think that's one, a celebratable moment, and two, we'd like to point out to the public that you saved their life, that the stuff that you did in those first few minutes with the help of dispatch literally helped save their life. And so we'd invite the press, so much that the press by about a year and a half was like, okay, you guys saved another one. And unless it was something out of the ordinary, they weren't actually sending reporters. But when it started, we were getting like reporters to almost every one of them. And then we get some really good PR out with the community. And every time that went out in the paper or on TV, we get a boatload of people signing up for kind of our free 1-hour hands-only CPR class.
Very cool. We've gotten a couple of sort of operational questions. You know, as you started to develop this program, obviously there was collaboration that needed to occur between the two of you and your individual departments, but who else did you have to sell this to and get permission to move forward?
Probably two-pronged on this. Obviously, our administration needed to be okay with us spending some time on this. And we do spend a little bit of money on awards and that type of thing. Initially, we took it to them, and they were great, very supportive, both at Ben Fire and at Deschutes County 911 of, yeah, go for it. And then it was really important that the dispatchers have buy-in on it and that the line level paramedics also have buy-in. So it really was, as Peter said, a collaborative effort, having lots of conversations. We never wanted it to feel like we're handing down a mandate for you to do this. Instead, we really wanted that culture of, I want to get CPR started because I see the good that will happen with it.
Yeah, exactly what Megan said. I went to my division chief and said, and at this time, I was just a line firefighter. I'm like, hey, chief, we need to throw some hours into this. I'd love to go to dispatch, you know, at least once a month and sit down with Megan and listen to these calls. You know, I can't tell you how many hours it potentially could be. It's going to flux with how many cardiac arrest calls we have and how much, you know, we might need to meet with people. And they were very supportive of it.
So from a departmental perspective, looking at costs to implement the program, obviously there were personnel costs in terms of staff time and training time and buying the awards and things like that. But was it otherwise, were there other costs associated with it that folks need to think about?
I don't know much that we discovered. It really was more the time of everything. I think that even going forward, we got better about listening to calls. It got quicker and stuff like that. But this is definitely a garden that needs to be weeded and tended. It has to be an ongoing QI piece. I mean, I know the big centers, and there are many bigger centers than us out there. You know, as Megan said, maybe start with a small sampling of calls and then figure out what's going to be the most impactful to your agency. But yeah, I mean, we still meet, you know, at least once a month on this scheduled and sit down and listen to that month's calls or what Ben Fire had to figure out where we can do better. And one of the things that I think that spun out of this, and we kind of mentioned that it's more than potentially just CPR in some of these things. You know, we've gotten some of these trauma codes. Now we're talking more about how quick are we getting to doing bleeding control on people when they're seriously bleeding. So more conversations have come out of this collaborative effort for sure.
Yep, I agree. It's amazing what it can grow into once you start working together on things.
I think I know the answer to this question. You've sort of already alluded to it, but it sounds like this is a program that will continue throughout the entire system, hopefully long after you both retire.
Yeah, I mean, that's the next piece. So how do we develop that so it is a sustainable program, right? I think the culture is definitely there that starting CPR immediately is going to go on regardless of who's here, but how do we also keep that collaboration of the data and looking at what we're doing, because new data comes out all the time and we need to continue to do course corrections.
Yeah, and I think that we're just now starting to look at succession planning stuff. We've sent a couple more of our folks up to the Resuscitation Academy and gotten them trained, and so I've started to work with them. Now they're doing so. Beyond just dispatch, we internally case review all of our cardiac arrests, pull the data off the monitors, look at every single compression second of the arrest, really focus on, as you mentioned before, pauses, why was this, 8 seconds instead of 5, really getting down into the nitty gritty. So I've got 2 people helping me with that now, but ultimately, training that next person to kind of continue this, because you definitely want someone impassioned and someone who can continue this, because it should live long beyond just us.
Hey, John, can I tag on to that real quickly, because it's such an important point for our everybody involved today. What Megan and Peter have done is phenomenal, and they're they're building and they're trying to weave this culture into their organization, and they understand that that's what's needed. The things they're doing, if they stop doing them for whatever reason, and this can happen, people get distracted, they focus on what we call the next new shiny thing. What will happen quickly is all the things that they've done can start to slip, because it really requires an ongoing iterative process. And they talk about this a lot in the Resuscitation Academy. This is really, the paradigm shift is changing the way your organization operates and what some of the focus is. And it's really important. What they've done is it's not a one and done thing. It needs to be continued. And that's really a key thing for everyone to understand.
Thank you, Dr. Bobrow, and we'll keep you on the line here for a second. In relationship to the CPR LifeLinks program, are there protocols that are being developed and both, I guess, protocols that agencies can use, pre-arrival instructions to help with high performance bystander CPR and things like that?
Yes, absolutely. So, in addition to the training and everything that goes along with that, we do have example protocols for pre-arrival CPR instructions. There are several different instruction models that are available. We're kind of agnostic to the different types of protocols. We give some examples, but we really, more importantly, give the background of what a protocol needs to focus on. It needs to focus on the dispatcher quickly, as early as possible in the call, determining if the person's in cardiac arrest. As early as possible, engaging the caller, getting them settled down, because frankly, often people are understandably panicked, and getting them to act. And some of the key ways to do that. So in addition to just the words, say this or say that, it's really about what a protocol needs to have in it, the goals of the protocol. Because frankly, right now, we're not 100% sure yet what are the best ways to say things, the right phrase, the right way to say things. And maybe it's even a regional thing. Maybe there's different words or phrases or terms that would work in different communities. There's some variability. So we do offer protocols and example protocols, but we also hope that people will take these and kind of try to customize them to their community.
Thank you. I do want to note that we have a survivor and a rescuer on the webinar with us. The rescuer who was talked through CPR and provided a very poignant comment. They simply said, "We are your why," which is fantastic, and thank you for sending that comment in. They also wanted to stress how important it is having those reunions and the fact that they are both for the survivors and for the lay rescuers. So, you were spot on when you were providing those comments earlier. What have you seen, for Megan and Peter, what are you using currently as a measure of success in this program? So first to the survivor and the person who did CPR, you guys, fantastic work. Super proud of you. That's amazing.
Yes, awesome.
So major success, Oregon is one of the states that reports to CARES network. So we report to the national database out of Emory and kind of turn in our numbers to those guys. But when we started, Oregon wasn't part of that. Seattle had a much smaller program that kind of allowed you to kind of collate your data locally, and that was free at the time. You could probably potentially still contact them. I know that CARES would like to have a lot more people, and as both of the docs have pointed out, I know the IOM report was also recommending a national database basically held by CDC to record all communities' cardiac arrest survival rates. Hopefully we're moving toward that. but I know that CARES, I think, is still backlogged with people who would like to get in, but that's kind of where we report all of our data to. And just to kind of where are we at, basically. So our last year survival rate was 54.5. In 16's data set, we spiked. And this could, remember, our numbers in Bend aren't huge. We're doing about 60 cardiac arrests a year, but we were at 71 for that year. So we were super excited with that number. But I'd say Bend's, and it's probably more fair to, because of our small numbers, kind of put a 5-year average on it. We're probably running right about 50% for survival right now. And we're super happy with it, but realize, you know, that we can grow. There are certainly, you know, high-flying departments and programs out there, Arizona, Minnesota, Seattle, where those guys' long-term survival rates are in the 60s. And this is definitely not a linear curve. It gets harder and harder as you get up there and above 40 and 50% to get more survivors.
And I just want to clarify, you're talking survival to hospital discharge?
Yeah, so that's really the only number that counts, Doc, right? Is that, you know, we use the CARES database, so that you've seen survival numbers, so people who walk out of the hospital, basically. Those are the people we're counting. Otherwise, you know, even, yeah, having great ROS rates is fantastic, but that's like running half the marathon. You know, great, you got them in the hospital, but they didn't survive that incident. So, you know, it's great that EMS can be good about resuscitating people in the field, but we've got to get them through the whole system and realize when we say the survival numbers, that really represents every part of the system. It's not just the fire department or just dispatch. It's everybody in the chain, from the doctors to post-resuscitation care.
50 to 60% is fabulous. You had made reference to CARES. Just to clarify for folks, CARES is the cardiac arrest, out-of-hospital cardiac arrest resuscitation registry. Ben, do you have any, and Megan and Peter, obviously, or well, not obviously, but it sounds like you're very pleased with the interface that you have with CARES. Ben, do you have any other comments about the CARES project?
Absolutely. So, you know, I said that the number 3 recommendation from the IOM report was this, what we're doing now to enhance the EMS capabilities. The number 1 recommendation was to have a national out-of-hospital cardiac arrest registry. And CARES has really grown to embody that. CARES is now, has been implemented across the country, in, I believe, nearly half the country, somewhere between 40 and 50% of communities are participating in CARES. I think it is an absolutely wonderful thing. It's essential, as Peter pointed out, to know where you start and to measure your progress, not just with the process of the care, but with the ultimate survival rates. And that's what CARES allows communities to do. It's not set up as an extensive research database. It's really set up as a quality improvement community measurement tool. And I would really advocate people, if they don't yet have some kind of registry, to investigate that. And many states, there may be some folks on the call where their states are already participating in CARES, and they could sort of piggyback on that. But you should look into it. It's the Cardiac Arrest Registry to Enhance Survival. It's been around for nearly 15 years, and it continues to gain momentum across the country.
Thank you. For folks that are interested in the CARES project, you can find that at their website is mycares, mycares.net. And we had mentioned the Resuscitation Academy. There are several states that have also emulated that model and are working together with the Seattle Kings County folks. I don't have that website right in front of me, but if you search Resuscitation Academy, I suspect it'll be one of the first hits that you get. And I believe they have a link there that also indicates where the various courses are being provided. We are getting close to the witching hour when we're forced to wind things down. I'll turn back just very quickly to Megan and Peter and Ben. Any final thoughts or comments or words of wisdom that you have for folks?
No, just thanks for listening to us today. I mean, that's kind of the first step, I think, to improving your system. And I think Megan and I are very excited to hear how other systems are doing and how they implemented this and how it was working for them. We look forward to hearing a lot more success stories.
Yeah, absolutely. And also just, I love how Dr. Barbaro said, just start a conversation. This can seem overwhelming at times, but don't let it. Just start a conversation and go from there.
That's right. Start small. It will grow. This is something we all can take on, and just don't be afraid to start this conversation. It's happening all across the country. We can dramatically improve cardiac arrest survival rates across the country. Thank you so much, everyone, for being part of this.
Thank you to all three of you for being willing to share your experiences with our audience today. I will remind the listeners that for those questions that we haven't been able to get to, we will catalog those and provide responses to them. Again, by way of reminder, this session was recorded and will be available in the next couple of days on ems.gov under the EMS Focus Program tab. With that, I'll thank the presenters, thank Red Flash for helping us with the logistics of getting this done, and thank you all for participating with us. Go out there and have a great rest of the day. Thank you, everyone.